Hi, it's Dr. Garza with Dr. Garza Plastic Surgery, and there's an important fight going on right now between physicians and insurance carriers with regards to breast reconstruction. The issue is how a specific form of breast reconstruction is being coded and therefore reimbursed. The reconstruction is called a DIEP flap. A DIEP flap is a procedure where a plastic surgeon uses the tissue from the abdomen to reconstruct a breast. This tissue is composed of skin and fat. It's a great form of reconstruction in that it uses the patient's own tissues and creates a very natural reconstruction. There are even instances in which this is the patient's only option for reconstruction. Patients who have had radiation or have had failed implant reconstruction are left with no great alternatives for reconstruction aside from using their own tissue. The two codes in question are S2068 and 19364. So those codes recognize a specific type of breast reconstruction. The older type of reconstruction, called a tram flap, TRAM, is when a plastic surgeon uses the entire rectus muscle on top of the skin and fat, and that is transferred as a unit. When this is done for both breasts, it is extremely morbid for the patients as it sacrifices the entire rectus muscle on both sides. This leads patients to have higher chances of having a hernia and significantly decreased core strength that will affect them for the rest of their lives. The S2068 code recognizes the DIEP flap, and the DIEP flap preserves the rectus muscle by careful dissection. And this is where the extra years of training really come into play. By dissecting out the blood vessel very carefully from the rectus muscle and preserving the motor nerves that go to the rectus muscle, patients have a much quicker recovery and a much better long-term quality of life. These advances in plastic surgery have happened over the past 20 years or so. Most plastic surgeons who are able to perform these procedures have had a full extra year of training on top of the 6 years of plastic surgery training that they've already undergone. Again, this is a very technically challenging procedure that most plastic surgeons in the country do not do. Those of us that do these procedures perform these complex procedures because it's very rewarding to us to have patients have great outcomes and have reconstructions who may have not had that experience otherwise. So now the issue is how insurance carriers want plastic surgeons to describe that procedure they're performing. We call that coding. Coding is how plastic surgeons describe the procedure performed to insurance carriers, and that information then conveys how we get reimbursed. This can all be very confusing to someone trying to understand the issue. A simple analogy that I think can help simplify things is a pizza shop that makes gourmet pizzas, has great ingredients, people love their pizza. Now an insurance company wants to come in and pay $2 for a $12 pizza. The $2 doesn't even cover the cost of the ingredients. And the analogy is that by cutting reimbursement, plastic surgeons are no longer going to be able to offer these procedures. Much like the pizza shop owner who cannot sell his pizza for $2, plastic surgeons are simply going to stop performing these procedures if we're not getting reimbursed appropriately for these complex procedures. DIEP flap procedures are one of the great medical advancements that's happened in microsurgery and in plastic surgery. We've taken a procedure that had significant morbidity for patients and refined it, and patients have great outcomes, low morbidity, and it is fantastic. If these changes happen, it's going to be a giant step back for patients who have breast cancer and need reconstruction. Our patients deserve better. Our moms, sisters, daughters, and wives deserve better. We all have family members or friends that have been affected by breast cancer, and to take away options is not an option. As doctors, our hubris creates an illusion of how medicine is practiced. We think we can decide how medicine is best practiced to serve our patients in the best possible way. But in reality, insurance carriers dictate how medicine is practiced. If procedures or treatments are not being reimbursed, guess what? They're not going to be performed. They're not going to be offered to patients because physicians have to be able to cover the bottom line, which is running a business or a hospital or whatever institution that they're working for. So if insurance carriers stop reimbursing, then they limit how patients are being treated and how medicine is being practiced. If these changes happen, the only patients who will be able to have access to this care are the wealthy. Very few patients can afford the out-of-pocket costs for these procedures, and that cannot happen. All patients deserve access to the quality care that we have in our modern day world.